Everyone, and thank you for joining us for our monthly webinar series. Before we get started today, I have a few quick ground rules to cover. As usual, we'll be keeping our phone lines on mute, but encourage you to ask questions. If you have a question, please put it in the questions box. We'll answer all questions at the end of the webinar, but if we do not get to your question, we have your contact information and we'll follow up with you in an email. We'll also be posting today's presentation on mceta.org in both video and presentation formats. Our presenter today is Bruce Mackey, our in-house Regulatory and Incentive Program Analyst. He will be walking us through the final rule and highlighting what is and is not sufficient rationale to use the new flex options, and covering other vital considerations before attestation. For those of you who don't know MCETA, we are the Michigan Center for Effective IT Adoption, a program that is led by the nonprofit Altarum Institute. We were chosen as Michigan's official regional extension center in 2009 by the Office of the National Coordinator. We're only one of 62 in the country. Our program is primarily funded through the Centers for Medicare and Medicaid Services and the Michigan Department of Community Health. We're here to help accelerate meaningful use of health IT in Michigan. To date, we have helped over 5,500 providers with EHR adoption and implementation. Our program offers subsidized health IT assistance for qualified physicians under grant funding. Paired with our fee-for-service offerings, we have meaningful use support, security risk assessments, targeted process optimization, which is a hybrid of lean principles and best practice applications, and attestation and/or audit preparation assistance. With that, I'm going to turn it over to Bruce to get started on the rule.
All right, thank you, Leslie, and thank you, everybody, for attending today's webinar. This is sort of a redo on a webinar that we gave when the final rule first came out a couple of months ago. This webinar is nearly identical, but there have been some additional clarifications that have come out since the first webinar. I recognize some attendees on today's webinar were also in the one that I did first of all as well. So most of the information is new, but there are some key and important differences from the first one. So with that, we'll kind of just roll right into looking at the different options. So back a couple of months ago, CMS kind of changed the rules on us a little bit and provided some flexibility in the technology that you are able to use to attest to meaningful use in 2014, as well as some flexibility in choosing which stage to use. And so prior to this new flexible final rule, there was really kind of two paths that providers were on in meaningful use in 2014. Everyone was to be on a 2014 edition of their certified technology, and you were either in stage 1 or in stage 2. As you can see from this grid now, there's really 10 different options available. So it really opened up a lot of options for folks to attain meaningful use based on the technology they're in, as well as the stage that you're in. So for folks that were in stage 1 or were scheduled to demonstrate stage 1 in 2014, if you have 2014 technology and you've had it the entire year, there aren't really any options for you. As you can look on the far right of this grid, the first box under the using 2014 edition cert to do, you can see that if you're on that 2014 edition technology and you were scheduled to be in stage 1, there is no option. That's what you're stuck with. You're stuck with attesting to stage 1 objectives and measures on that 2014 technology. The only way that you'd be able to flex still is if you can use an earlier reporting period before you upgraded. So if you were on that 2014 technology for the entire year in 2014, then there are no options. But if you can back up and use, let's say, Q1 or Q2 because you didn't upgrade your technology until Q3, then that's going to provide you some of these flexible options still. And sort of the same thing in stage 2, if you were scheduled to be in stage 2 and were on 2014 technology for the entire year, there are no flexible options available to you. The only way, again, to use the 2 options that are in the lower right-hand corner of this grid is if you're able to back up and use an earlier reporting period from before you upgraded, when you were still on your 2011 edition certified technology. You, again, still have to be on certified technology for meaningful use. So there are options available to you if you are on the 2011 edition, and then, of course, on the 2014 edition. I want to talk just a minute about the middle column here and define what combination means. It can mean a couple of different things. So some folks are still using a modular EHR, which means they are kind of bolting together different components, probably from different vendors, to kind of create your EHR package. A combination could mean that some of those components are upgraded to 2014, and some of them are still 2011 technology. That would put you in this combination column in the middle, which, as you can see, provides the most options out of any of them. The other thing that a combination can mean is when you choose your reporting period, if part of that reporting period was on your 2011 technology and part of that reporting period was on your 2014. So in your 90 days or in your 3-month reporting period, your 1-quarter reporting period, if you upgraded in the middle of that reporting period, that would also put you into this combination column, which would provide some additional options for you for flexing. Kind of gives you the option, basically, to choose the 2013 version of meaningful use or the 2014 version of meaningful use. And at the bottom of this, I want to note, and I'm going to stress this probably too many times in this webinar, these options are not available to everybody. There is a very important qualification, and it is only open to providers who could not fully implement the 2014 edition technology for your reporting period in 2014 due to delays in 2014 edition CERT availability. So this is, it means you couldn't do it and it was no fault of your own. So this is a vendor issue only. So if you dragged your feet, and I'll talk about this again later on a future slide, if you dragged your feet and just didn't sign up or whatever it was, if the reason you're not on 2014 technology is your fault, you can't use these options. You are stuck with where you were before. The flexible options are not available to you. But if you can demonstrate, as a whole bunch of folks can, that you could not upgrade due to vendor certification issues, your vendor didn't get 2014 certified in time, or didn't do it with enough time that gave you time to get fully implemented, or if you've upgraded to your 2014 technology and there's some issues with that technology and you're waiting for updates, or there's something going on with the reporting, then it's going to open up these options. But again, that's a very important distinction, and if you're audited, you don't want to be on the wrong side of this one. To overview the final rule. So these new regulations were effective on October 1st officially, but the options are available for the entire 2014 program year. So it provides you with these flexible options where you can back up to all the way to Q1 if you want to, using these flexible options. But officially, the regulation went into effect on October 1st. These new options were not available to first-time meaningful users who are trying to beat the 10-1 attestation deadline in order to avoid the 2015 Medicare hardship penalty. And the reason for that is that CMS, both the CMS and MDCH attestation systems were not upgraded by October 1st. So you would not have been able to attest to one of these earlier reporting periods in order to beat the 10-1 deadline. CMS has come back and given, they made a very generous, I would say, or a very important exception here, where they reopened the hardship exception for first-time meaningful users only. So again, if you've heard that the hardship exception period has been reopened and you have until 11/30 this year, that is only for first-time meaningful users. So that is really it's for those folks who were trying to attest by October 1st or needed to attest by October 1st. And really it's those folks that maybe they thought they were going to be able to attain meaningful use because their vendor told them that their upgrade was coming, and they thought, you know, okay, we're going to be able to attest to meaningful use this year to avoid that 2015 payment penalty, but then something happened, or you got upgraded and then the product broke, or whatever it is. So if you missed that original July 1st deadline, you've now got until November 30th to get that hardship exception. But it is only for first-time meaningful users, folks that have not attested to meaningful use in the past. The new options are available only for those providers and hospitals who could not fully implement due to delays in 2014 edition CEHRT availability, as I've already mentioned. Again, I will touch on this a few more times in here, because that's really the main distinction that I need everyone to understand. These are not available to everybody. These options are available for 2014 only, and in 2015, everyone must be on 2014 edition CEHRT. And if you if you're in your full reporting year, if you're beyond your first year meaningful use, that means you need to be on your 2014 edition CEHRT on January 1st. You don't necessarily have to have everything implemented. If you're still working on your portal or maybe your ERX, those individual modules don't necessarily have to be live. Of course, it's best if they are, but you absolutely have to be on your 2014 edition certified technology on January 1st if you are in a full year reporting period. And as it stands right now in 2015, all providers are going to be on the hook for a full year reporting period in 2015. There's still there's a chance that that's still going to change. There's some legislation that's in the works right now that might force a second year of a 90-day reporting period for everybody, just like we saw in 2014. That might happen in 2015, but we kind of have to wait and see what Congress does on that one. But there's a chance that everyone will be doing 90 days or a 3-month period in 2015. So stay tuned for that information. To qualify for AIU in the Medicaid program in 2014, you must be adopting, implementing, or upgrading 2014 CEHRT only. That also applies for, in 2014, MDCH also gave folks the option of bypassing AIU and going directly into meaningful use. Doesn't mean you miss those AIU dollars. It just kind of shifts your payment year and your program year a little bit. So in your first year of meaningful use, you would get the $21,250 instead. Those folks also have to be on 2014 edition technology. So in the Medicaid program, if you're a first-time meaningful user, you have to be on 2014. The flexible options are not available to you. Likewise, if you're going to AIU in 2014 in Medicaid, it has to be on 2014 CEHRT only. Again, first bullet, I will drill into over and over again. Anyone that's choosing these flexible options, you're going to be attesting that you're able to use these options because you could not fully implement your technology, your 2014 technology, because of issues related to availability. At the time of attestation, the CMS and MDCH systems are going to look at the certification number that you put in. That's the number that you go to what's called the chapel, the CHPL. We call it the chapel. You go to that CMS website and find your specific certification number for your technology. When you input that at the attestation site, there's a real-time check, and to see it's only going to give you the options that are available for that particular piece of technology. So if you put in, let's say, a 2011 edition certification number, it's not going to give you the option to attest to 2014 meaningful use. It's only going to give you the option to attest to the 2013 version of meaningful use. And if one of the flexible options is used, everybody needs to have and keep documented proof to back up that claim. So this is in the event of an audit. You're going to want to make sure that you can prove that it was okay for you to use that. CMS hasn't been appropriately vague on what that documentation should look like, and it's really because there could be a whole host of different reasons that that would cause you to be able to use these flexible options. MCETA recommends that you have documentation of your of vendor contacts regarding your 2014 edition CEHRT installation. So dates of initial requests or the date you signed your contracts or addendums, any kind of documentation of vendor delays in installation or the training, documentation of bugs or issues that prevent or delay you from fully implementing the 2014 edition CEHRT. And so any documentation of bugs or issues that prevent the practice from achieving one or more of the measures or that present any safety issues. That can include trouble ticket numbers, dates of submission, stuff like that. Any kind of email exchanges with your vendor contacts to document the practice action in resolving issues are also important to have. Any minutes from internal meetings that are held to address issues stemming from vendor delays. So you can see that there's a lot of options available. Just make sure that you've got something in your audit file that demonstrates that the issue was on the vendor side and not due to your own inaction. And when I say vendor, that could be your actual EHR vendor. Vendor in the final rule is very broadly defined as value-added resellers or anyone, the people involved in the actual installation. If it's not the actual vendor that's doing the installation, if you're working with a VAR, and it's due to their delay. So vendor is a very broad term, and it doesn't just mean the person that programmed your EHR or the company that programmed your EHR. On the topic of CQMs, which I see a question already came regarding that as well, and perhaps I'll address it here. So the CQMs are going to, you have to make sure that you are matching your CQMs with whatever version of meaningful use you are attesting to. So if you are backing up and using the 2013 version of meaningful use, you're also going to back up and use the CQMs that matched that program year. So prior to 2014, CQMs were very different than what they were intended to be in 2014. So in the 2013 version of meaningful use, you were reporting on 6 out of 44 CQMs, and that was 3 core or alternate core and 3 menu. In 2014, that changed, and you are reporting on 9 out of 64 CQMs, and the 9 that you choose have to cover at least 3 of the 6 NQS domains. One clarification I've recently seen, there was a great question that somebody asked in another webinar that I was on, and they asked, okay, so what if a CQM has gone through an update? So CQMs, you might be on, when it originally was issued, it might have been on version 1, but let's say in 2014 it's now on version 3. Do I have to back up and use that previous version of the same CQM? The answer is no. It is okay to use the latest version of that CQM. So if version 3 is out, it's best to use version 3 and not back up and use that older version of the exact same CQM. That was a good question that came out that I hadn't previously seen. So again, make sure that when your CQMs are matching the program year of your meaningful use. And also, just to clarify, if you're backing up and using the 2013 CQMs, you can only report those through attestation. There is no e-reporting on those. So even if you have even if you have upgraded to your 2014 edition CEHRT, it doesn't necessarily mean that you can't use the flexible options. while certainly the timing of the product installation can come into play, also, another thing that might open up the ability to use these flexible options is the deployment of new processes and workflows and employee training. And so even if you've gotten a fully functional 2014 CEHRT, you might still be able to use those flexible options if you can attest that you didn't have enough time to fully implement the new software. So you could not get all the staff trained and workflow issues addressed and whatnot. So it's still possible if you can attest to that you just didn't have enough time. And since 2011 edition technology is incapable of reporting on stage 2 measures and objectives, if any providers that use only 2011 edition CEHRT for their 2014 reporting must flex back down to the 2013 version of stage 1. Just talk a little bit about how the programs progress from here, or if you end up taking a break in 2014 and not attesting to meaningful use. If you're in the Medicare program, just like it was before this new flexible rule, whether you meet meaningful use or not, the stages and years progress without you. So if you take the year off, let's say you were going to be in stage 2, year 1 this year, but do not attest to meaningful use, you're going to be in stage 2, year 2 next year. So the clock continues to tick without you. And likewise, if you do use the flexible options, if you are on the hook to be in stage 2, year 1, and are able to use these flexible options, and you instead attest to stage 1 again, you are in next year. You are still in stage 2, year 2. So this year, no matter what you do, it still counts for whatever it was you were supposed to do this year. And in Medicaid, it's essentially the same in that no matter what you do this year, it takes the place of what would have been your normal 2014 attestation, except in Medicaid, you don't have to attest. You can actually take a break and not lose out on those incentives. So you can still take a pause in the Medicaid program and come back in next year. But if you do attest in the Medicaid program, it takes the place of whatever your 2014 attestation would have been without the flexible rule. And the final rule also clarified that stage 3 begins in calendar year 2017, which we all knew was coming, but the final rule just put it in stone for us. So what is sufficient rationale to use these flexible options? So as I've said already a few times, the sufficient rationale has to center on a vendor delay, or basically something out of your control that prevented you from getting your 2014 edition CEHRT fully implemented. So that it could be the software development, an actual certification delay. There was a lot of vendors that just recently finally got certified for 2014. Let's say they just got certified in September, October, didn't give you enough time to get that product installed. Implementation issues, whether it's just getting in the queue and with your vendor and they couldn't get you upgraded, or from there, some issues with the actual implementation where even though you're upgraded to that 2014 technology, there's something wrong with it and it's preventing you from meeting some of the measures. If you're unable to adequately test the updated system, again, just a delay in the product release, a delay or missing software updates. A lot of the 2014 edition technology, while they got certified, when it came to actual installation, there's been something wrong with the programming, bugs in the system that have prevented folks from actually attesting to meaningful use. So you might be kind of waiting for software updates to fix some of those bugs. In some instances, the software itself just renders the provider unable to reliably use it. Software doesn't contain the required components, not enough time to put that new workflow in place or adequately train staff. You kind of get the notion here that the basis for using one of the flexible options must stem from a problem with first getting the software installed because of vendor delays, and then fully implementing the 2014 CEHRT in time for a full EHR reporting period in 2014. If the reason you have falls into that green box, then you are going to be able to use those flexible options. So the flip side, what is not sufficient rationale? Well, really just about anything that didn't fall into that green box on the previous slide. But the main distinction here is who caused the delay. So if the issue is caused by the EP or the EH or the critical access hospital, then the flexible options cannot be used. So some things that were specifically called out in the final rule, but is certainly not exhaustive of all the things that are not sufficient rationale, would be financial issues, such as the cost associated with implementing, upgrading, or installing, testing, or other similar financial issues. Financial issues do not give you sufficient rationale. These are very expensive to put in, but that doesn't mean that you can not attest to meaningful use or can flex down to the lower options. The inability to meet one or more of the meaningful use measures is not sufficient rationale, with one exception, which I'll touch on slide 17, and that is the summary of care measure in stage 2. Staff changes or turnover, also if you're high on both of those, which is unfortunate and happens, but does not give you sufficient rationale to flex. And providers' inaction or delay, or your organization's inaction or delay. So if the EP or organization just waited too long to engage the vendor, the vendor had certification and had the bandwidth to get you upgraded in Q1 or Q2, and you just dragged your feet and didn't get in the queue to get that upgrade, you're going to be out of luck with flexing. The EP's inability or refusal to purchase the software updates, or if you did have it installed earlier in 2014 but just delayed the training, testing, or implementation to later this year, that's going to take you out as well and mean that you're not going to be able to use the flexible options. Some additional points to consider. So with the public health measures, if you had previously done the test in stage 1 for the public health measures, both in MICR and syndromic surveillance, and you are flexing and you're reporting on the 2013 stage 1 measures or the 2014 stage 1 objectives and measures in 2014, you don't have to redo that test. Your prior test is going to count for this one. Although you should still send an email to the public health measure, to MDCH, just to notify your intent. They might be looking for you to move from testing into full production, especially if you are crossing from stage 1 into stage 2. But if you're flexing back down to stage 1, just send them a quick email and say, hey, just want to let you guys know we are flexing and staying in stage 1, so we're not going to be moving into full production. It's just really, it's not in the final rule, it doesn't call that out, but in talking with the state of Michigan, they would like to see that just for their own auditing purposes. That way when CMS can come to them and say, hey, why hasn't this provider progressed into live reporting and being fully onboarded, they can say, we got this email from them indicating that they are flexing back down to stage 1. Practicing in multiple locations, this one can be tricky. A lot of words on here, more words than I like to put on my slides, but I copied this, most of this directly out of the final rule, and I think it's important to kind of lift exactly how it's worded in the final rule to make sure that you get it right. So EPs who are practicing in multiple locations, which have been unable to fully implement, you may attest using those flexible options. And if you're using different technology at the multiple locations, you can choose the option that is best applied for your patient encounters across all locations. So if some of them are on 2014 technology, some are on 2011 technology, you can kind of choose which is best applied across your patient base and use those use that version of meaningful use in that stage across all of your encounters. But just like in any other meaningful use year, you're not going to exclude any visits that take place at a site that has certified technology, whether it's 2011 or 2014. You're going to use the patient data for all encounters that are equipped with certified technology, no matter what you do. However, If over 50% of your patient encounters occur at a site that is equipped with 2014 edition CEHRT, which has been fully implemented, you're not eligible to use those flexible options, and you would therefore limit your denominators to only those patient encounters in locations equipped with fully implemented 2014 edition CEHRT. So we've had a number of conversations with folks that have ended up in this however category here, where some of their locations are upgraded and some are not, but that the ones that are upgraded equals more than 50% of their patient encounters, so it kind of takes the flexible options off the table. But as a caveat, you can then limit your denominators to only those locations that have the 2014 edition CEHRT. So it's kind of good news, bad news. On the summary of care measure, I mentioned there was one exception to being able to flex due to the inability to meet one of the measures. It is on the summary of care measure in stage 2. So folks that were on the hook to be in stage 2 in 2014, if you have found that you cannot meet measure 2 of the summary of care measure, and that is where you are electronically transmitting your summary of care document directly from your certified technology to your referring provider's technology. If you're finding that your referring providers are not ready to accept that electronic summary of care, which means they have not fully implemented 2014 technology for whatever reason due to vendor delays, if you find that you're ready to send it, but your referring providers are not ready to send it, that's going to qualify you for this kind of limited exception, and still qualifies for the inability to fully implement. So in this one measure, and it's only for the summary of care measure and measure 2 of the summary of care measure, the inability to fully implement is extended to the referring providers. So if you're going to flex with this reason, the referring provider must retain documentation clearly demonstrating that they were unable to meet that 10% threshold for this specific reason. And likewise, this one's a little tough as far as the documentation goes, because it means you're fully implemented, but you somehow have to document that your referring providers have not fully implemented. So again, as far as documentation for your audit file, you want to make a historical list of the recipients of past referrals or transitions of care, including volume numbers and or the percentage of total referrals or transitions of care. You can contact these recipients and find out whether they are installing 2014 edition CEHRT. Document that these recipients are not able to fully implement 2014 edition CEHRT due to issues related to the availability. And given the above documentation, ensure that the EP would not be reasonably able to achieve the 10% threshold for that measure. As long as you can kind of do all that, you can also flex and not be in stage 1. You can, or not be in stage 2, sorry, and flex back down to stage 1. You might find that it might be easier with a 90-day reporting period in stage 2. Again, the exception for this, or the exclusion for this particular measure, is less than 100 transitions of care during your reporting period. So you might find that you might be able to stay in stage 2 and just claim the exclusion, even if there's kind of dual reasons. Your referring providers are not ready to receive your summary of care document. That might be a main reason why you can't meet measure 2 of this particular measure, but also you might just be able to claim the exclusion on it. Look at those transitions of care, and if you have less than 100, it might be easier just to stay in stage 2 because you've done all the work to achieve stage 2. Can't meet it for this one measure due to your referring providers not being ready. But also, if you can claim the exclusion, you might just do that in stage 2 as well. One last slide here before we get to questions. What about the SRA and the yes/no measures? So this slide is significantly different from if anyone was on the first time I did this webinar. We've had some additional clarifications and changes that have come out of CMS since then. So CMS has recently relaxed the requirement with regard to the SRA and the timing of when the SRA needs to be completed. Prior to this, your SRA needed to be completed during your reporting period. They've completely relaxed that for a lot of good reasons, the flex rules being one of them. But now, as long as your SRA is done any time during the program year, but before attestation, it counts. So, you know, if you want to back up and use a Q1 or Q2 reporting period, but still haven't done your SRA, it's still okay to use those earlier reporting periods. Just make sure you get your SRA done prior to attesting. So it has to be done in 2014 and has to be done before you attest. But as long as you can meet that requirement, your SRA counts. This is also good for folks in larger health systems that might have providers that are in different stages, or some folks that are in their first year, so are only doing 90 days. And this will come really into play next year. And these SRA, the flexibility with the SRA will continue. This isn't just for 2014. It goes forward into 2015 as well, when we enter into a 365-day reporting period for folks that are beyond their first year. But the large health systems might have folks that are in 90 days as well as a full year of reporting. As long as you just get that SRA done anytime in that in the program year, and it's going to count for all of your EPs, no matter kind of what the reporting period is in 2015. The yes/no measures also, this one can be a little bit tricky. So you are supposed to be able to have proof that the yes/no measures were enabled during your chosen reporting period. But if you're flexing now and are going to back up and use a Q1 or Q2 or Q3 or reporting period, and you didn't get those screenshots, that can still be okay. Best case scenario is your EHR is one of them that can actually, when you run the reports, it gives the actual date that that the functionality was turned on, and that's like your formulary or your drug and drug allergy checks. Some EHRs can actually just report the date that they were enabled. If that's the case, that's great. A lot of folks have to capture screenshots for that proof, but as long as you can kind of reasonably demonstrate or logically demonstrate that while you didn't get a screenshot during the reporting period, let's say you got a screenshot from earlier, maybe in your first reporting period in 2013 or whenever, that demonstrates that those were turned on. And you can grab a screenshot now that shows that they're still enabled. CMS is okay with kind of logically interpreting that, you know, in all likelihood, you didn't disable this functionality during your reporting period. So they're okay with kind of you logically demonstrating that these were most likely turned on during the reporting period. So that would still allow you to flex and still meet the measures. All right, that is it for the slides. I want to open it up to questions. We've had quite a few come in during the webinar, and we'll get through. We got at least 20 minutes here to address the questions. So let me start off here. One question regarding CQMs was the first one that came in, and I think I addressed that. So again, make sure that whatever CQMs you're attesting to match the Meaningful Use program year that you're using. So if you're backing up and using the 2013 version of Meaningful Use, you want to back up and use the older rules when it came to CQMs, as well as the smaller list of CQMs as well. So remember, it went from 45 to 64, so you can only use or 44 to 64. You can only use the smaller set if you're backing up to the 2013. Let's see. Next one. It's a long one. Hold on. Let me read this. We have met Meaningful Use in 2013. We plan to start our measures 10/1/2014 for 90 days. So it's not 90 days. Let me qualify that. If you've already met Meaningful Use in 2013, it's not a 90-day reporting period. It's a 3-month reporting period. If you do 90 days, you're going to short yourself a couple of days there and open yourself up to failing an audit. We could not get our portal together because of vendor-to-vendor issues. I am not sure where this leaves us. All other measures are met. Could you give me any information on what this means for us? As you said, we are not attesting for the first time, so we cannot do the hardship. So if you have not been able to get the patient portal up, that is a failure to fully implement. And again, as long as it is the vendor that has created the issue for you, and it is the vendor delays that have caused you to not be able to get your portal up, then absolutely, that means you have not fully implemented your 2014 technology. And for a stage 1 person, so you'd have been in stage 1, year 2, that is going to open up the ability to back up and attest. Well, let me clarify that. Depends on when you upgraded to your 2014 technology. Let me back all the way up to the first slide. We can look at that grid again, because it depends. It is entirely possible that folks are not going to be able to meet meaningful use due to their vendor delay. So it depends on when you upgraded to your 2014 technology. If you were still on your 2011 edition CEHRT and can back up and use one of the earlier reporting periods from when you were on that 2011, then you're going to be able to flex. And get my mouse over here. It's gonna allow you to flex back down as long as you can show that you were on your 2011 technology for an early reporting period. You're going to be able to flex to the 2013 version of stage 1. However, if that's not an option, either because you were upgraded earlier this year or for the entire year, or if you back up and you weren't meeting the measures in earlier this year in Q1 or Q2, if you still have to show that you met all of the measures and objectives. If you didn't meet those measures and objectives, obviously you can't attest to meaningful use. So it's entirely possible, and it's really unfortunate that some folks are not going to be able to attest to meaningful use this year by no fault of their own. It's actually their vendor that's going to cause them to take the year off and potentially miss out on the incentives. So yeah, that's not great news, but it's entirely possible. I think you got to press those vendors hard to get the stuff in. Also, if you're still able to get that portal up, it's okay that the portal was not live on the first day of reporting period. If you can get your portal live now and still meet the measure, you still have to hit that in stage 1 that 50% of your patients are up on your patient portal. You can still meet the measure, so there could still be time to use your Q4 reporting period as long as you can get your portal up and running and still meet the measure. It is okay that the portal itself was not fully implemented on October 1st. Long answer. I hope I answered it for you. Next question. If you have a 2014 CEHRT number, but were only able to do part of the upgrade, but due to software problems could not apply the fixes, or the fix came too late in the year to get 90 days of data when you go into a test, would you use the 2014 CEHRT number or 2011? We have registered both numbers in the system. Let's see. Let me read that one again. When you did part of the upgrade, so it depends on if that means you're on a modular EHR, so you're going to be able to fall into that combo column in the middle. Let's see. Yeah, it's going to depend on when you upgraded in the year. If you're able to back up and use an earlier reporting period from before you upgraded, that might be an option for you. But obviously, you're not going to be able to use. It doesn't look like you're not going to be able to use a Q4 reporting period on your 2014 technology. Yeah, the CEHRT number that you use, it just depends on which reporting period you're using and what technology you were on at that time. So if let's say you upgraded, if you're backing up and you want to use Q1, and Q1 was when you were on your 2011 technology, you're only going to use the CEHRT number for the 2011 technology. If you're using a reporting period where you were on both pieces of technology, so part of the year you were on part of the reporting period you were on 2011 and part of it was on 2014, then you're going to use the certification number you use would be that combo number where you're putting both of them into your basket and generating your CEHRT number. If that, feel free to ping me after the webinar for that particular question, Cheryl. If that does not answer it, we might have to get some additional information on that one. So I'll have my email up at the end here. Feel free to shoot me an email. You can also call me, 734-302-4744. I'd be happy to address that if that does not answer your question. Do you mind sharing the slides from the presentation? They are up on our website right now. If you go to mceta.org, go to the resources section, click on webinars. There's a PDF of this slide deck there for you right now. With this being recorded, will the recording and presentation be available later for use? It sure is. As I said, the PDF is already there. Within the next few days, we should have the video recording of this posted on our website as well. Let's see, next question. In the state of Michigan, the only entity that counts for reporting, is the state of Michigan the only entity that counts for reporting to a public health agency? What about the ability to report to a local health department? And what if you use the same EHR as the local health department? So for the in stage one, the public health reporting measures are MICR and the syndromic surveillance. So it is the only options are the state of Michigan ones. So for the immunization registry, you have to interface with MICR, and for the syndromic surveillance measure, it has to be with the Michigan syndromic surveillance system. So the state of Michigan options are the only two that count for public health reporting in stage one. Is summary of care also for every referral for specialty care, or only if you are transitioning the full care of the patient, i.e. to the hospital, long-term care, another PCP? So summary of care, it is for any transition of care to another provider of care. So if you are sending the patient from you to anywhere, to any other provider of care, that counts as a transition of care, and the summary of care measure applies. So it's to any specialist, to any other doctor, any other provider of care at all will count in the summary of care measure as a transition of care. The only kind of transition of care that wouldn't count is if you're just in like mental health, for instance, they hook up their consumers with other like community resources, like maybe housing or financial kind of services and stuff like that. Those don't count as a transition of care because that's not another provider of care. So if you're referring them, if you're keeping them in healthcare basically, and going from you to another healthcare provider, that's going to count. If the EMR does not allow the customization, what can I do? They can only report stage 1 or stage 2 and not a combination. So there is no combination. You're either going to report on stage 1 measures or you are reporting on stage 2 measures. There is no combination. You do not mix and match the measures from stage 1 to stage 2. So your EHR is very right that there should not be that customization. You cannot pick and choose stage 1 and stage 2 measures and kind of piece them together to attain meaningful use. You are either in stage 1 or stage 2, and it's either in the 2013 version of stage 1 or the 2014 version of stage 1. And then there is only one version of stage 2, and that's in the 2014 version of stage 2. There's no such thing as the 2013 version of stage 2. Question. I think it came to me in a couple. I'm going to piece this one together. I am on stage 1, year 2 measure. Okay, this one came in 3 different parts, I think. I am on stage 1, year 2 measure. I am reporting the last 3 months of 2014. What do I need to report? So it depends on what technology you're on. So the person, you're in stage 1, year 2, and you're reporting the last 3 months of 2014, so you're halfway through your reporting period. What do you need to report? So it's going to depend on what technology you're on. Are you fully upgraded on 2014 edition technology? If so, you are you're here on the get my cursor over there again. There we go. If you're on the 2014 edition technology, you are reporting on 2014 stage 1 objectives and measures. If you have not upgraded to 2014 and you're still on 2011 edition technology, and you can demonstrate that you have not been able to upgrade due to the vendor delays, then you're going to be able to flex back down and do the 2013 version of meaningful use instead. But it all depends on what technology you're on. All right, next question. For the 50% multiple locations, does place of service 22, titled Outpatient Hospital Services, count towards the 50% threshold to become? That all depends on if that place of service 22 is on certified technology or not. So if that place of service 22 is on certified technology, if you have an EHR, it has to be counted. If it is not yet on certified technology, and that's either 2011 or 2014, it doesn't matter. So if it's on certified technology, it has to be counted. If it is not, you do not calculate those in your 50% threshold for that 50% rule. So it all depends on if they're on an EHR or not. Let's see. Also, can I fill out the form for CMS that I cannot attest because of this? Okay, this is a part 2 to a question. This is part 2 to the question I read off. If the EMR does not allow the customization, what can I do? They can only report stage 1 or stage 2, not a combination. Also, can I fill out the form for CMS that I cannot attest because of this? The other situation is I cannot do the labs because our local hospital does not want to interface with my EMR. So depends on if you're a stage 1er, then labs was a menu. Stage 2, it's a requirement. So again, I guess it all depends on what you're doing there. If you're going to flex, if you're able to flex down and only report on stage 1, then labs are not an issue for you, since that is a menu measure and you can choose others. Maria, we might have to take this offline as well. If I have not answered your question already, give me a call afterwards, 734-302-4744, and I'd be happy to talk through your particular situation. You're also asking, how can I get a copy of the combination for custom reporting from your slides? Is it in the CMS site? Maria, give me a call afterward. Let's talk about your situation. I want to make sure that that we iron out your situation. It might take a little bit of back and forth for me to fully understand what it is that you're trying to do. If software can provide reports that drug or formulary functionality was on at the beginning of reporting period, is it still necessary to have provider-specific screenshots? No. If your software is one of them that that reports that the date that the functionality was enabled, then you don't have to do the whole screenshot thing. You're one of the lucky ones that do not have to worry about screenshots because your software it provides the report that those yes/no measures were turned on at the beginning of the reporting period. What happens if we can't meet percentages in stage 1 core measures 11 and 12 because patients do not want PIN and don't want clinical summary? Do we lose payments through no fault of our own? So the clinical summary doesn't, you don't have to give that it's okay if you offer it and the patient refuses. You're still providing that clinical summary. So you still hand it to them even if they throw it in the garbage right there in front of you. That's perfectly okay. You'll still meet the measure for the clinical summary. If they don't want the PIN, so we're talking about patient portal access. Patients can opt out of the patient portal and still get counted in that particular measure. So for patients that are opting out of electronic access, you want to get them to sign an opt-out form. There's no real regulation on what that opt-out needs to have. I would suggest Googling, just going online and Googling patient portal opt-out. There are a lot of organizations that have posted their opt-out forms that they have online. You don't have to reinvent the wheel, or can give you some good ideas about what your opt-out can or should look like. So again, if somebody does not want the PIN or token or whatever it is that you're generating for patient portal access, if they don't want patient portal access, have them sign the opt-out form. That then allows you to count that patient in the numerator for that particular measure. So you can still get credit for having offered them the patient portal, even if they choose not to use it. Again, that is only for in stage 1, the patient portal measure, where 50% of your patients need to be given the patient portal access. And in stage 2, the same thing can be done, but it only satisfies measure 1 of the patient portal access. You still are on the hook for getting 5% of your unique patients to view, download, or transmit, and you're still on the hook for 5% of your unique patients to use the secure messaging function of your EHR. But the opt-out it still allows you to say that they were provided access to your patient portal for that 50% measure, even if they choose not to use it. Let's see, next question. Thank you, Bruce. Wonderful. Hey, you're welcome. If an EP uses a proprietary EHR, not third party, can they still use the rationale that vendor issues prevented them from moving forward to the next stage? If by proprietary EHR you mean a non-certified EHR, no. So the only way you can take part in any part of this meaningful use thing is if you are dealing with certified technology. So that EHR needs to appear on the chapel. Barbara, if that doesn't answer your question, again, give me a call afterward. I'd be happy to talk that through. But if by proprietary EHR you mean it is their own homegrown version and it has not gone through and gotten certified, then no, it's not going to be able. You can't use that as rationale. And again, if what you mean is the vendor is not trying to get certified, if they're not moving towards certification, then no, that doesn't count either. You have to be attempting to get a certified technology in order to play anywhere in the meaningful use space. Can I repeat the site? Okay, so to print the slides, if you go to our website, that's mceda.org, and go to the resources section, you'll see a link to webinars, and you'll see this PDF as well as all our past webinars posted there as well. And my phone number to call me afterward is 734-302-4744. I have that on my last slide also. Oops. There we go. There's my information. My email as well. Feel free to shoot me an email or call me if you have any additional questions. I have 2 new providers who are not using an EHR because ours is not ready for pulmonary templates, yet they have never attested before. Can I submit the exception form for them? And will they be able to start next year at stage 1? If you have 2 new providers who are not using an EHR because not ready for pulmonary templates, no, that's not going to count. So if the rest of your providers are up on 2014 technology, the fact that you don't have pulmonary templates is not going to qualify you as for vendor issues. Just because the specific templates don't have to be there in order to meet the meaningful use measures. Yeah, from what you're describing to me, Nicole. We are not fully upgraded. We are doing the flex rule. Oh, thanks for that clarification. Yes. So for those folks, yes, you're going to want to get, because they've not yet achieved, they're first timers. As long as they have never attested before. So yes, because you're using you're flexing because you're not fully upgraded yet. Yes. Those 2 new providers would qualify for the newly extended hardship exception. So you want to get those applications in by November 30th, and that will take the 2015 Medicare payment penalty off the table for you. And then, yes, you would still start out in stage 1 next year for those 2 new providers. If you are up on web portal, then clinical summaries need to be given to patients. The clinical summaries need to be given to the patients anyway, whether you're up on a portal or not. Just the web portal gives you the option of uploading your clinical summaries to the patient through the web portal. But even if you don't have the portal up, the clinical summaries, they need to be delivered to the patient within 3 business days. So that includes just printing them out and handing them to the patient right there at checkout, dropping them in the mail to the patient, or if you have the portal up, then you can upload it to the patient portal, and that qualifies as having delivered it to the patient as well. If the patient portal opt-out form is utilized, how do these patients get calculated in the numerator? So it depends on your technology. Some of the EHR vendors have a little checkbox for that patient that indicates that the patient opted out. If you do that little checkbox, it's going to count in the meaningful use measure. A lot of the vendors do not have that option. I'm hoping they add that option because it's going to make your lives a lot easier. But you can manually count those folks. If you do not have the ability to record it as structured data in your EHR such that it triggers your meaningful use measure and automatically puts them in the numerator, just keep track of them manually. And you can manually add those patients that opted out into the numerator when you go to a test. So you'll still be running your meaningful use report and then counting the number of opt-outs that you had. If your system is not automatically counting them, you just add those into your numerator manually and keep record of it. You want to keep your opt-out forms in your audit file again, so that you can show that it was okay for you to manually add those opt-out patients into your numerator. But it becomes a manual process of just adding them if your EHR does not have the ability to record it as structured data. I think we'll see that for nearly everybody in future versions of the EHRs. At least I hope so anyway. There should be the ability to record it as structured data. Back to the earlier question about the proprietary EHR, the clarification says the proprietary EHR is certified. It's homegrown and certified. So if they're certified, then it's a certified EHR. So can they still use the rationale that the vendor issues prevented them from moving forward? Yeah, if it's a certified EHR, it doesn't matter if it's proprietary or not. I mean, if that means if it's not necessarily available widespread. If it's a certified EHR and there are vendor issues that are preventing you, then the same, whether you're using NextGen or eClinicalWorks or whatever, or just a little kind of homegrown one that has gotten certified, the same rules apply either way. Again, Barbara, if I haven't fully answered that, give me a call. I'd be happy to talk about your specific situation and advise you further. All right, we are well past 1 o'clock. So thanks for everyone that hung on. That is all of the questions. Again, if you have any further questions, feel free to shoot me an email, give me a call. I'll be happy to talk through your specific situation. Leslie, I'll turn it back over to you for any closing remarks.
Yeah, so as many of you probably already know, we have our next webinar scheduled for December the 10th, and we're going to be talking about getting ready for 2015 reporting and stage 2. So join us for that. Otherwise, we appreciate you coming along, and thanks, Bruce, for all the good information.
You're welcome.
Bye.